in the chat area. There's below that, you can also, next to your name, you can raise your hand, and Lori will do her best to unmute you as well to be able to activate that function. Great. So with that, thank you for joining us. Welcome. I'm Michael Pasha-Orlo. I'm professor of medicine at Boston University School of Medicine. I've had a kind of enduring interest in things that are complicated for patients and families, and complicated in a particular way, in particular for people with limited education. This is a field that some people call health literacy. And health literacy is a lot of things to a lot of different people, so we'll get into this a little bit of what is this. And today's talk is really about the intersection and interplay of health literacy and PCORI. We're doing this in part in deference to and in support of and the support of PCORI. And let me see about advancing these slides. Here we go. We at Boston University are happy to have been the recipients of Eugene Washington PCORI Engagement Award for the second time now. That's helped support particular activities at a conference that we've been running. We funded and have been running the Health Literacy Annual Research Conference, which we call HARC. There will be the 10th annual conference, 10th HARC meeting. It will be, again, back in Bethesda, Maryland, in October 22nd, 23rd, 2018. I'm hoping that by being with us today, that maybe some people will be motivated to join us at HARC this next year. I will mention some things about HARC from last year and also from HARC from this coming year, our 10th year. This coming year, two keynote speakers. One will be Raymond Ownby, Professor and Chair of Department of Psychiatry and Behavioral Medicine and also of Public Health and Bioinformatics of Southeastern University. He's been involved in a bunch of different health literacy-oriented research activities. In particular, he's helped create something called Flight Vitas, which is one of the tools that people can use to measure health literacy at the patient, at the individual level. And he's also going to be talking about a mobile app that he's developed and currently evaluating, targeting older adults with low health literacy to help improve their ability to manage chronic health conditions. And also a keynote speaker will be Maricel Santos, who is fantastic as well. She's professor of English at San Francisco State University. Her focus has been on English to speakers of other languages, and her research area it directly melds into this space because she's done research on the health impact of participation in adult basic education and English as a second language participation, and she and colleagues and a network of her colleagues explore the effect of peer support networks in health literacy and health outcomes, in particular amongst immigrant adults, adolescents, and adult learners. And I'll mention something else about Maricel later on when we get to it. So the goal of this session, more particularly, is to talk about health literacy and patient-centered outcome research, and about their intersection and potential synergies. I think I have to spend much time in definitions for this group about what is PCOR, but effectively the focus here is about, I have some little chat buttons and stuff. Okay, now I can see my own slides. How patient-centered outcome research can help people and their caregivers communicate and make informed healthcare decisions, allowing their voices to be heard and assessed in all aspects of care, but in particular to assess the value of healthcare options. Now, literacy, kind of broadly speaking, is a functional concept. It really relates to competence in a given set of skills to have power and effect in a given set of human endeavors. So there's really no one literacy. Any kind of literacy that you think of has to have a kind of contextual framing. So the capacity to, say, fix a car is a particular context, a particular area of skill, or use a computer, or to succeed in healthcare. These are just different contexts. Now, there are some basic literacy skills that can make all of these things easier. Reading, writing, arithmetic, what some people call numeracy. They're useful, but those are actually the kind of building blocks for applying and having skills in a domain of human endeavor. So, you know, there's really no abstract thing. It's all in a context, and we'll get to how important that is when you think about health literacy as we go. The official definition of health literacy from Healthy People 2020 and different federal agencies that have been participating in this is the degree to which individuals have the capacity to obtain, communicate, process, and understand basic health information and services needed to make appropriate health decisions. I want to spend a few minutes on this because actually I think this definition is really deficient in very particular ways. Let me just explain some of them. To start with, the definition as endorsed here, as depicted here, this is the official definition for the U.S. government, use the concept of basic. And I'd like you to think about how this doesn't work. To say health literacy is contextual means that you can't really have the word basic in the definition. That is, what's basic to one person, say, for example, a person who has asthma, and it's critical for them to know to use an inhaler and to use an inhaler and this and that, that would be irrelevant to another person who doesn't have asthma. And so what's critical to one person, a person has cancer, has to engage in a process to decide with caregivers and family members about, say, surgery or chemotherapy or radiation. That's critical for that person, is basically irrelevant to another person who is not faced with that scenario. So you have to just kind of envision the enormous contextual requirements for any particular person, how they go through life. So it's very hard to have the word basic in the definition. The next thing I want to point out is it's not just information and services, but it's also skills. There are lots of skills involved. It doesn't just magically happen that the clinician gives you a glucometer and now you know how to use it. Without understanding how to use that glucometer, you can't provide value. You get value information for your sugar readings, and if you have diabetes and that's what you're facing, that's going to be a critical skill to you. The next thing I want to point out is that it's really not about the capacity to make appropriate health decisions. This is very much a critique that comes out of the PCORI space because it's not about appropriateness. Appropriate from whose perspective? The doctor's perspective? No, it's about having these skills and capacities to make informed health decisions. And this really harkens back to the definition of PCORI itself. It's about empowering patients, families, communities. It's not about controlling. So it's not about appropriateness. It's about informed. What I want to point out in the definition itself is the word individuals. The skills of individuals will be important, will be relevant, but it has to be called out because ultimately it's not really only at the individual level. These are phenomena that are fantastically impinged on by system phenomena. If the clinicians are always talking in jargon, it's really lopsided to just say this patient has limited literacy skills. You need to have you need the other side of the coin and say, what are the capacities of the clinicians to communicate, like with people who are not clinicians. it's not just the clinicians, it's also the system. Why do we make it so complicated to succeed as a patient and in public health as well? So anytime someone thinks about health literacy, if they only think about at the individual level, it's really, really easy to go astray. We need the voices of individuals, but we need them to also help attune our senses to the unnecessary burdens that are being placed on individuals. The corrections may happen at the individual level, but the corrections may also happen at the system level, at the societal level, at the community level. With that, there's just many, many things, many, many examples, just almost everything, how we enroll in health insurance plans, and we get letters in the mail and say this is not a bill, and people don't understand what they are. You know, there's just so many examples of ways that we make things way too hard and complicated. It's actually gotten more and more complicated. There's more information. We've flipped a switch, basically, from not having access to information for patients and families. Now there's so much information that we basically are swimming in it all the time. You know, the internet just gives you access to a tremendous amount of information, not all of it I value. There's not enough time. The clinicians frequently don't have enough time or give enough time to patients. We're asking people to make extremely heavy cognitive tasks, you know, when they're not at their best. And in fact, we're asking patients to do more and more. There's more information being put into the patient's space, direct-to-consumer advertising, direct-to-consumer genetic testing. The goal, in some respects, is laudable to have participatory shared decision-making, informed decision-making. It's a very important transition that we're making, but we have to acknowledge that that does put extra cognitive burden, extra challenges in front of patients, and we have to think through how is this going to work? What are we going to be needing to do in order to succeed in the agenda of shared decision-making and patient-centered care? Actually, a bunch of different conceptual domains for what is health literacy, and some of these we'll get into a little bit more, but maybe not have enough time for everything. Yes, there are basic skills. It's easier to be a patient if you can read and write and understand numbers and understand forms. Document literacy is how to interact with forms and understand forms. You know, there are particular documents that are you know, common in healthcare, like for example, the document of a medication bottle. And there's just a lot to understand and know. There's that you use this to, it encodes power that you have to get more medicine, but you have to understand how that system works. You have to interact with forms to, you know, get benefits, and there's just a lot of ways that we don't make that all that easy. Many things that are disease-specific, but there are also things that are kind of beyond disease-specific, how to communicate about symptoms and how to understand when people are communicating back to try to empower you about, say, symptoms and decision-making, problem-solving in healthcare. Most of healthcare is actually done by patients for themselves in their homes, not while sitting with a clinician. All the decisions about you know, how to care for oneself at home, and how do we support that, and how do we empower people for problem solving in those contexts. How do people improve their capacity to appraise all the information that's coming their way? There's a lot of work to be done in health literacy. One thing that we've done in my team here at Boston University along the way is we've been collating and curating tools that have been developed to measure health literacy at the individual level. At this point, that's what we've focused on in the toolshed, the health literacy toolshed, and you can come to this website and see what we've done. It's continuing to grow. In fact, there are already 133 tools in this shed where there have been validation data presented in the peer-reviewed literature meeting our criteria. There's different languages, different disease contexts, different populations, and it's really a bit of a complicated field, and it's continuing to grow and hopefully improve. This is not the focus of today, but I do encourage people to check this out and to see that there's actually been a fair amount of work and continues to be a fair amount of work in this space. And much of it is trying to improve the role of the patient's voice in care. So 133 tools. So we have I believe, 10 more on the docket to come in the next month or two. I have a few slides now to talk about the prevalence of low health literacy in the United States. I want this to be the main focus today, so let me just go quickly. This is data from the National Assessment of Adult Literacy. In this tool, they're low basic, basic, intermediate, and proficient. This shows you that, in fact, 36% of adults in the United States had below basic or basic literacy skills in large national assessment of adult literacy skills. It's broadly thought that, to anything like shared decision making without a significant amount of support, that you would need to be, really strongly above that level. So there's a lot of people affected here. This shows that there's a massive interaction between race, ethnicity, and literacy skills. That phenomenon is also directly related to income and educational attainment. The one large message in the whole conversation is to stay in school, and what's needed to be done to help people succeed and stay in school, what needs to be done to have the schools be good. Here's another snapshot of this. These are data from the National Assessment of Educational Progress. This is data. This mechanism is this is a recurring study of 12th grade students' skills. This is a slide of reading achievement for 12th graders in 2015. And the next slide is going to be for numeracy, for math. And it's pretty disheartening. This is for people who've stayed in school to 12th grade, and you can see that there's room for improvement, and also just significant, striking racial and ethnic disparities in educational attainment. I want to note that over time, that actually there's been a very, very good positive improvement in having a high school diploma or GED for young adults. Between 1980 and 2001, there's been significant improvement, as you can see in the right upper corner of this slide, but still really very large racial and ethnic disparities. This is important because I and others have shown that health literacy is actually a significant driver of racial and ethnic health outcomes, disparities in racial and ethnic health outcomes, and I think this is really one of the kind of ecological variables that put in this direction and is the cause of it. There's another assessment tool. This is data from 2012 and 2014 from the program of the Adult Assessment for Adult Competencies, the PAC program, with the U.S. data. This is focusing on young adults 16 to 34, and it shows a very similar story, both for literacy, reading, and for numeracy. These are just very, very large effects, and shows that the health system is massively too complicated for many, many people. Another way that you can look at this phenomenon, this is another project that I helped develop. Anyone can come to this website, Health Literacy Map at unc.edu. This is a national map of the United States. You can focus down on state, also local, and a zip code level. And you can download the data if you want for local purposes or for national analyses, however you like. And basically, we brought together several different data sets to create this demographic representation nationally about health literacy and the prevalence of different levels of health literacy. I hope this is useful for folks. So does this matter? It matters a lot. It matters because ultimately literacy and health literacy, low health literacy, has been associated with many, many health outcomes, many more than are on this slide. I made this slide like 8 years ago, and the list has continued to grow and grow and grow. I'm just going to show one example, and that's from the example of mortality, low literacy and mortality. This is one of a handful of studies that have looked at this problem, and this shows for elderly folks, you'd be 66 years old to get into this study, and followed over the course of 80 months. These are hazard ratios that are controlled for blood pressure and BMI and smoking and diabetes. And so, to have a 50% increased risk of dying over the course of 80 months, controlling for these other phenomena, is a very, very large effect. This is just shows that there's just a lot of to care about health literacy and to think about how we can improve the system and empower patients, decrease unnecessary complexity in so many different ways. So more assertively, I'm going to spend some time talking about how this leads to a synergy with PCORI. Now, first thing I want to talk about is really a stakeholder engagement. The second thing is about the collection of data, and the third thing is about interventions. So stakeholder engagement, there's a lot of work that's been sponsored by PCORI, where there have been really good stakeholder engagement plans, but not necessarily including people who have low health literacy or stakeholders who actually know about literacy. And I think ultimately it's very important to engage stakeholders, but some of that effort should focus on the inclusion of people with this voice, the inclusion of people with low health literacy, and stakeholders who know about this, either personally, from their family, or professionally. There's a lot of ways that people can be in a role of a stakeholder for PCORI programs that can bring out that voice. With these perspectives, it's really quite easy to fail to understand and respond to the needs of this particular type of vulnerable population. Without an explicit effort, it's fairly easy to end up with a highly educated group of stakeholders who actually don't represent the needs adequately of people with health literacy. I want to point out, I'm happy to see in the group today, I believe I saw Danny on the line. Danny was one of our stakeholders at I have a video chat, so maybe you can even wave to the group if you can hear Danny. There you go, fantastic. Was one of our stakeholders at HARC 2017 at HARC 9. People can't hear you, Danny, but you made a thumbs up if it was okay. I'm talking. You're muted, so I don't know if Lori can let him be unmuted. But well, then if you get unmuted, Lori's working on it. Okay, so maybe give a thumbs up if at least for now. So yeah, all right, thank you. So also Laura's also here. We have another stakeholder who's also on the line. I just got a chat message from another one as well. Thank you very much. And so you can communicate on the chat function. I lost that. Oh, you did. Okay. Now, Danny, you're unmuted. Talk to people. I think so Danny, I think you're unmuted if you want to talk at some point. It looks like Janice Tufte is also online, also participating. and wants to annotate something that on a screen. So maybe I just let her do that if she wants to. Just you can write if you want to. I'm not sure if I did something wrong on the screen. Okay, so let's turn that off. Okay. I think I tried to let you do that. Sherry also is a PCORI ambassador. Is also on the line too. So you can. She sent that as a chat to me, perfect, privately. Laura K wrote that HARC's been great. Okay, so I think part of when you think of stakeholder engagement, I think of to design this for success. One mean is like, so we were running a conference, so I think that each stakeholder can be, you can engage with each person to design a path for them that matches their interests through the program. We had a 2-hour pre-meeting session, maybe even went longer than that, on health literacy and PCOR to get the most out of the meeting. People had information in advance. They could prepare questions, and the moderators were oriented and were specifically told that the stakeholders, PCOR ambassadors, were to be given space, no question, to ask questions and hopefully start off the question asking. And then personally, I thought one thing that was really good, and I got a lot of positive feedback, was that we charged the stakeholders, we charged them with approaching people to challenge presenters. To say to people things like, tell me why I should care about this work, or tell me how this research of yours that you're presenting here on this poster, tell me how this will advance the voice of patients, or whatever it is. People could take that in whatever direction they wanted to, but charging people with that energy to go and engage with people to help make the participants at the conference actually understand that these people were there, that they had an agenda, and that there was actually work to be done to bring their research to be effective for patients in empowering them. In HARC 2017, there were 13 stakeholders, and it went very well. Sherry sent me another note privately, but Sherry, I encourage you to send that publicly to the whole group. Just wrote to me, long before PCORI became popular, we nurses need and tailored information at the level of understanding. And you also sent it privately, send it to the whole group. And he wrote, yes, the participants and presenters were quite open, helped stimulate my work over the whole year, which is great. People, you don't have to only chat to me. You can chat to the whole group. There's an option for public. I'm unable. Okay, so I'm sorry. On my screen, I have an option to send to everyone. Maybe not everybody has that option. So if I get, I'll continue to read them out then. Sorry about that. Sorry about that. So we have 19 stakeholders signed up for 2018. So there you go. So you have to do the drop down button there, and then you can send it to everyone. Then see it yet, but it's okay. If you see something private, I'll read it out. Okay. So the next thing I wanted to point out, and by the way, if Laura sent it out to everybody, excellent. The next thing I guess the last thing on that, just before we move on, is that I think that a lot of the people at the meeting were really charged up by being engaged in this way, and really were kind of turned on by having stakeholders come and press them and ask them these questions. How is this work going to improve patients have power, or whatever questions people asked them. It was working. And it was about 13 out of, say, 250 people there for health literacy focused research at that last meeting. And this year so far we have 19 stakeholders signed up. The next topic I wanted to just focus on is about the collection of data and the importance of health literacy and PCORI in that sense. He wrote privately, but for everybody, that maybe the poster presenters were the most engaged. Because there you have a scenario where you can actually have a one-on-one conversation with the investigator in front of their work, and then you really have a chance to say to them, tell me how, or is research doing what you want? Is research advancing the empowerment for patients? Or whatever people challenge them with. Yes, I think the poster sessions are a good way to engage with people like that. In the collection of data, there's a lot of scenarios where data collection has been designed without really understanding the challenges of people with low health literacy. There's just many barriers that data collection systems have been designed without validating them, without affirming that they work for people with low health literacy. The mode of data collection, if the data collection requires reading and things like that. There's also linguistic barriers. Even if a person can read it, but the added semantic and cognitive burden in it being able to do it. There's also the answer formats. Also many conceptual barriers that frequently happen. So I just have to say, and I'm going to say it multiple times, pilot testing is critical. And when items are confusing, you collect bad data. And with bad data, you get bad research. There's no simple correction for this. You just need to. It's just not useful to go into the field with bad data collection. There's many ways that low health literacy impinges upon this phenomenon. You say low English proficiency, but that's really not, as a subdomain of this topic, but that doesn't really capture enough of it. The words are can be, that doesn't mean the meaning is transferred. And many instruments have been validated but inadequately. So having systems that allow people to go at their own pace, having systems where it's read to the patients, having systems where the research assistants or the staff facilitating the collection of data actually can support the participant in how they go through the process. Most research assistants are trained to not support participants when they collect data because we worry about social desirability bias. We worry that this is going to introduce bias into the data collection. But people don't understand the questions. It's just not going to work for you anyway. So there's just a lot of barriers. One of the techniques that many tools use is this concept of reverse coding. But whenever you have a reverse coding item in a survey tool, you're basically making an added linguistic and cognitive challenge to the patient, to the participant, and it just frequently leads to bad data. Just have to be kept as short as possible, and really pilot testing is critical. A lot of times built into our surveys are abstract notions that just lead people astray, and in particular people with limited health literacy. Oftentimes people are just dealing with so many things in front of them that this is just a lot of ways to end up bad data. and interaction between some of these phenomena. So factors such as fatalism or stoicism have been shown to be more common in people with low health literacy. And these are kind of double negatives in terms of like how they influence people as they respond to our data collection program. So it's, you got to test, and you got to validate with the target audience, with people with limited education, limited literacy, limited health literacy. Ultimately, face-to-face, all the studies that do data collection over the internet, to actually have a representative sample, like 90 million Americans with low health literacy, many of whom are not doing, Turk-based internet surveys, So you have to think, are you going to be able to get data from the target audience? And really, there's really no justification for not including people with low health literacy. Partly is critical. Electronic systems for collecting data, but they don't necessarily accommodate people with low health literacy. One step forward in this direction would be audio copy, where items are read aloud by the computer system if for whatever reason you need to do electronic data collection. But there are a lot of other ways to support this. Cognitive interviewing techniques of engaging people qualitatively to understand how they interpret the questions, what the questions mean, and what the data collection methods will be are going to be incredibly important because most of the tools out there to collect data have not been validated with people with limited health literacy. This is just more notes about the same finding methods to do data collection, which with limited health literacy is going to be critical. The third topic, the last topic here, that I'm going to be talking about is about engaging the target population in the development and evaluation of interventions. Ultimately, we collect data because we want to improve the system, we want to improve the world, we want to improve patient empowerment, and that means figuring out how to changes and to prove that changes are appropriate, so intervention research. And so, from beginning to end, people with limited health literacy and people with the voice of patient-centeredness should be involved in the design and development of assessments and the assessment of programs of interventions in this area. So this is another type of stakeholder engagement. This is stakeholder engagement in as part of the development team for the intervention, and then all the way through to advise in the process of the assessment of any intervention. And there's just many ways to eye off the ball on this. It's a kind of an ongoing effort to make sure that that interventions are designed in a manner that can be used, will be used by people with limited health literacy skills. A very common failure mode, a very common way that this gets messed up is that if everybody just puts more and more and more in there, and frequently more is not better. Filling people with data often is not empowering. And data that you want to empower someone with needs context, needs support, needs meaning. People need help to see how this provides meaning and empowerment in their lives. So one question that just came in, sorry if I hadn't noticed it for a bit, but was about the issue of targeting populations for learning health systems. And a lot of the work that learning health systems do is driven by data, by big data. At least that's the main agenda of learning health systems to date. I think it will be fantastic and a fantastic positive step that learning health systems would include in paneling participants, in paneling target audience members for the learning health system, in particular people who have limited literacy skills. That would be a fantastic step forward for way learning health systems do their business. For the most part, what I see from learning health systems now, it's a big data-driven enterprise, and it's very hard to capture the voice of patients and hard to capture the voice of limited health literacy through big data analyses. With that, I want to just make a few points. We actually started a journal in this area. Health Literacy Research and Practice is a journal that started at the beginning of 2017. I'm the editor-in-chief of this journal. We would love to hear from you in this journal. We actually have a submission that I'm working on right now from two of our ambassador stakeholders, and we're in the process of applying to PubMed for inclusion of the journal in PubMed. It takes several years usually to get into PubMed. It depends on a lot of factors, a successful publication history. We're actually well underway, and we already, not even a year and a half into this, have an application in because of our early success. And I'm very enthusiastic that I'm very hopeful that we will be in PubMed soon. And once you're in PubMed retroactively, everything you've published will go into PubMed. That's just how it goes. I just got a private note from another stakeholder who's also preparing a perspective piece for the journal, which is fantastic. As part of the conference and as part of the PCORI funding for the conference, we have a plan to have a series of articles about patient-centeredness and health literacy, including perspectives from stakeholders. So that's why it is you hear me talking about that. Here's a list of some of the health literacy-oriented projects that PCORI has funded, and I'm going to just give one example. I believe the lead author is on the call, and so Lori, I don't know if you're able to unmute Dr. Fabry, who I believe is on the call. Dr. Fabry was kind enough to send in some slides that I'm going to talk about now. But if you're unmuted, you can also talk about this, of course. So this is a study about health literacy and outcomes for patients with heart failure. It's a prospective community study, and here's the first publication out of the project. Effectively, this was a survey of people who have heart failure and looking at their outcomes using mostly data from the survey and also from the Rochester Epidemiologic Project. It's adjusted for age, sex, education, marital status, and comorbidity. Effectively, what they found was that people with low health literacy have a much higher rate of mortality and a much higher rate of being rehospitalized. So to put this in context, if you look at on the bottom left-hand panel, observed over the course of 1 year, 12 months, after heart failure diagnosis, that adjusting for these factors, age, comorbidity, and marital status, and adjusting for all these factors, couldn't be lackadaisical about it. Adjusting for these factors, age, sex, education, marital status, comorbidity, that there's 1.9 change, so like almost a doubling, effectively, almost a doubling of risk for death within 1 year after a heart failure diagnosis. There's a very large effect, and in particular, if you think if you're adjusting for education level, so these are very large effects. You can see on the right also for the hospitalization, cumulative hospitalizations that occurred. With that, I'm going to plug the conference again for people who are interested or potentially interested. If you have questions about it, please send us an email, and then I'm going to see if anyone has any questions or comments at this point about health literacy, PCORI, or intersection thereof. Lori, if someone sends a note privately asking to be unmuted for a question, or if people can send in a chat, it'd be useful as well.
This is Lori. I think I've unmuted everybody, so if anyone has a question, they could ask it verbally or send it through the chat.
Put it against that little section.
If you'd like to, sure.
So I don't have to walk up and down stairs to do it. Above it is no longer the shit above it is no longer there, and there's a fire.
So if someone's trying to talk with us, that's great. If you're not trying to talk with us, then it'd be great if you would mute your line. Matteo, I don't know if you wanted to make any other comments about the slides I shared from your project?
This is Theo. No, I think you cover all of it. So that was very interesting. The thing that we saw actually about health literacy that could be eventually interesting is that at least in heart failure, the effect was larger for mortality than hospitalization. So it looked like these patients actually have also a barrier when it comes to being hospitalized.
I mean, without being too crude, if you die, you also don't get hospitalized another time.
Yeah. Yeah, but so using the Anderson-Gill method that we used for hospitalization, we kind of took care of that statistically. So not only they just die, so they are not hospitalized, but there is also a barrier to being hospitalized among patients with heart failure and inadequate health literacy, at least from what we saw. But yeah, that was just it.
Not great, but so the next question, of course, will would be then what's to do of what you're planning or thinking in the next phase, because this is actually scripted.
So one thing that we actually are working on is the patient-centered communication, because we are trying to, so we have described a problem and we are trying to come out with eventually a solution or an intervention. And one of the things that we really believe could be at the base of, of why adequate health literacy is associated with this outcome is that the patient not engaged with the healthcare provider as much as she could. And so trying to look at patient-centered communication and how does this construct affect the outcome and if it's related with health literacy.
Yes.
But we work in it.
Yes. I think heart failure has been such an interesting one. It's gotten a lot of attention because of the remission reduction program, identified really high rates for readmission. If I sold used cars and 5 of the cars was broken again before even a month, you took the car off the lot. You say that I was a bad used car salesman, that I sold lemons, and you would complain and you would bring the car back and say, I want my money back. The product is that bad. More than 1 in 5 will come back within a month, heart failure. And so that means that the product is not very good. You know, the hospitalization experience, you know, more than 1 in 5 come back. So we basically do not succeed in empowering patients, families, the PCPs, everybody in adequately adjusting diuretics, the sodium intake, the fluid, all the different parameters for success. And you can see that such interventions actually have reduced readmissions for heart failure patients by, say, 1/3, which is a huge effect when you think about it. And most of them are working through intensive educational interventions and empowerment interventions at all levels. That can't just be only one level. So I have a question that came in, wobbling. Can you talk about the circumstances that might lead to wobbling in an individual's level of health literacy? I'm not sure but what the wobbling is that you're talking about, Carol, but so when, at least to me, when I think about yes.
You can do it with
Oh, so I thought that was a clarification on the question, but I think what I think this is.
Michael?
So they, in fact, learn how to take care of their asthma, but still not be empowered with respect to their heart failure or diabetes or something else. And also, you know, people can learn and be empowered. And so there are providers that are more supportive and providers that are less supportive. Our tools are not good at capturing this. Our measurement tools have not been validated for repeated use of measures over time to exemplify and exhibit the learning effect, other than our subjective tools. So if there's a whole set, maybe a fifth of the tools that are on the Health Literacy Toolshed website are actually subjective measures. So asking patient how to rate their own skills in different dimensions. And those, in theory, actually should be a little more to change time and may, in fact, reflect either improving skills individual level or at actually improving system phenomenon. In fact, in Europe, mostly health literacy is measured as a subjective phenomenon. And the reason why they like that is they say this will give a better chance at seeing if system is appropriately accommodating the skill levels of the patients and members of the communities. And so in Australia and in Europe, the approach to measurement is subjective measurement, and they have elaborate programs to do so, measuring nationally representative data in subjective health literacy skills. In the U.S., we have not done that. In the U.S., we tend to focus on objective literacy skills, with feeling that subjective measures really have no ground truth to them. It's all subjective. So for example, just, one problem that's seen with the subjective measures is that this is, the men tend to rate their subjective skills higher than women, for example, even though, without any basis in actually doing that. So, other kinds of problems with that, like, people, younger people, for example, without much experience in the healthcare system, tend to rate their subjective skills better than older people. And there's many reasons for that, but part of it is because they just haven't been sick as much and haven't had to interact with just overly complicated, obviously unnecessarily complicated systems. So, I think we're going to come towards the end. If anyone had any other particular question. Oh, there was a question I had missed earlier about historical context of health literacy. Well, I think, to be honest, health literacy is a movement that really did come out of a lot of, come together with threads from a lot of different places. People were talking about patient empowerment well before health literacy came along. People were talking about patient education well before health literacy came along. But it's a banner under which more threads have come together and I think have been strengthened. And it has evolved. In the beginning, health literacy really did focus almost exclusively on the skills of patients. And now it is really more normative, quite normative, to that anytime you think about a patient's skills, that right away you should also think about the provider's skills and the system burdens and bring this all together in one fabric. It's if you talk about the patient's level of self-efficacy to communicate about their questions and concerns and symptoms, well, how can you do that without also talking about the provider's self-efficacy to communicate effectively with patients? They really together. And interventions that look, for example, to improve, say, outcomes for people with heart failure, really, any and all opportunities to improve matters need to be taken because our outcomes currently are good. I know, for example, in Dr. Fabri's data, almost twice as likely to die in 12 months after a diagnosis of heart failure. But, even people with adequate health literacy have almost a 10% rate of death in 12 months. That means there's a lot of room for improvement, and whichever options we have, we should take. If they're at the individual level, at the societal level, at the social level, in how we train and in reinforce behavior for providers and their systems, we can do it. So with that, I'm going to close this up. I hope I get to see many of you at the HARC conference this year. Thank you for being on the line and making this hopefully a successful session today. Also, for people who are watching this after on a taped version, you also please send me a note if you have any questions or concerns, and maybe we can continue the conversation in a much more amenable format, face-to-face, in Baltimore, in Bethesda. All the best. Thank you.